enigmatic force, a rare presentation of IgA nephropathy as IgA syndrome. Introduction. IgA nephropathy is a glomulopathy characterized by IgA deposition in the globular mesangial region. IgA nephropathy complicating leukocytoclastic vasculitis is rarely documented. Spondyloarthropathy patients can be more frequently affected by IgA nephropathy than the general population, and a common etiologic mechanism can be involved. My case report is a 21-year-old man who is a student presented with chief complaints of pain in the large joints since 10 years, with recurrent episodes of rash on bilateral lower limbs 6 years back and again twice last year. History of present illness, patient was apparently normal till 10 years of age. Complaint started as pain mainly in the large joints, initially started in the bilateral knee joints at 10 years of age, followed by the involvement of bilateral ankle joints, followed by the involvement of bilateral hip joints. He had bilateral stiffness mainly in the hip joint, more on the right side, over the course of 10 years and associated with restriction of movements. History of rash initially present on the lateral aspect of the right ankle, which is shown in the first picture, which progressed to involve both the lower limbs associated with itching, non-blanchable rash with abdominal pain. The abdominal pain was diagnosed as appendicitis, and appendectomy was done 4 years back. Rash reappeared and recurred again. On examination, the rash was small, 0.5 to 1 centimeter purple colored rash present on bilateral lower limbs extending till buttocks, which is palpable and healed. Hyperpigmented patches are seen in the second picture, are present on the lateral aspects of ankles. On examination, straight leg rise test was positive, which is painful at 30 degrees on the right side and 45 degrees on the left side. Faber test was positive on both sides. Modified Schauber's test was 5 centimeters, which correlated well with his age. Investigations, CBP, PTINR, APTT were normal. CU showed no RBC or RBC Cas. 24-hour urine protein showed greater than 1 gram per day. Eye examination was normal. HLA B27 was negative. All other investigations were normal. Serum IgA was in a higher limit, that is 486. Vasculitis profile was normal. On skin biopsy, the image is showing histopathological features of leukoclastic vasculitis with immune deposits, which is consistent with HSP vasculitis. MRI is showing bilateral sacroiliitis, as the arrow is showing narrowing of the sacroiliac joint space, and T2W intensity, hyperintensity is seen in the MRI picture. And the renal biopsy showed IgA deposition in the mesangium. He's been treated with ARBs for proteinuria and mycophenolate mofetil for renal involvement. His proteinuria decreased. He is referred to rheumatologist for further management. Discussion: this is a rare case of IgA nephropathy associated with IgA vasculitis and seronegative spondyloarthropathy. The investigation of renal manifestations in patients affected with spondyloarthropathy has not been a routine recommendation, but doing a biopsy helps in establishing involvement of the kidney. References were given here. Thank you.